Good afternoon, and welcome back to Philadelphia Magazine's ThinkFest 2020. I'm Tom McGrath, editor of Philadelphia, and I want to thank you for tuning into this conversation about the future of healthcare and public health in Philadelphia, featuring Dr. Ezekiel Emanuel from the University of Pennsylvania, being interviewed by PhillyMag contributor Queen Muse. The COVID-19 pandemic has not only upended life and caused much death around the world, but it's revealed some deeper issues about our city and our country. We're pleased to be able to have a conversation about some of those issues today. Before we get to our conversation, I'd like to say thanks to the sponsors that have helped make this event possible, including ThinkFest presenting sponsor, Bank of America, St. Joseph's University, T0 Group, and Paperboy Media Group. We'll be hosting these ThinkFest conversations all week long, with sessions at noon and 4 p.m. I hope you can join us for all of them. In today's conversation, Queen Muse will interview Dr. Emanuel for about 30 minutes, and then we'll have about 15 minutes of audience questions. Thanks again for tuning in. I hope you enjoy the conversation.
Hello, everybody. Thank you so much for joining us today, and welcome to today's edition of ThinkFest. My name is Queen Muse. I'm a digital contributor for Next Health PHL, and I'm very excited to have with me today Dr. Ezekiel Emanuel. He holds and has held many titles, including having served as a health policy advisor for the White House under the Obama administration. Dr. Emanuel also currently serves as the Vice Provost of Global Initiatives at the University of Pennsylvania. He is the co-host of the Endeavor content podcast, Making the Call. And he also has a new book coming out, Which Country Has the World's Best Healthcare? A topic that we can all get behind and dig into and have interest in. So that is available for pre-order on Amazon now, and will be out in bookstores on June 16th. Dr. Emanuel, thank you so much for joining us.
Great to be here. Thank you.
So I think a good place to start is to take a good look at where we are right now. Lots of states are starting to reopen, including Pennsylvania being one of those moving from red to yellow and kind of lessening some of the restrictions we've seen over the past few months due to coronavirus. And for months, we had this advice from experts like yourself saying, stay indoors, stay away from one another. And now we're hearing advice that it might be better to go outdoors, right? So I wanted to hear your opinion on sort of why has this advice changed and how do you see the pandemic evolving over the summer months?
Well, it's interesting. I actually have been one of those people that you've got to go out of doors also for your mental health, but just stay away from everyone else and take walks and be safe and wear masks. I've actually not thought that simply sealing yourself off in the house was necessarily a good idea. I did think that we could go outside and take walks and walk around the block or walk in parks and be 6 feet away from someone else and wear a mask. And I have continued to maintain that. I think the sort of lockdown in the house and never going out, and believe me, I have a lot of friends who've done that. I think that actually makes people a little more stir crazy. When they go out a little more, feeling like they're liberated and maybe not adhering to all the physical distancing rules that are really important to reducing spread.
Yeah. And I think that's really great that you're supporting this idea of us getting out more, because you're absolutely right. Several points have come up just about that being a good thing for your mental health. But this has been a virus that has sent a lot of experts into a frenzy, in that I don't think I've ever seen a virus or a disease that has led to so much contradictory advice. So what are your thoughts with regards to that? In your years of experience, have you ever seen a disease or an outbreak that caused so much contradictory advice? And why is this virus in particular so difficult to understand?
Well, it may seem like a lot of contradictory advice. I think it's important to understand that we've known about this virus for only about 5 months now. And we've known the clinical symptoms, certainly firsthand in the United States, really only for about 3.5 months, really since the start of March, end of February. When you're trying to learn about a virus, you're trying to learn how it behaves, you're trying to learn how it affects the human body, there is lots of uncertainty. Every case is a learning experience, but a case may be sui generis. It may not be typical. And so you might extrapolate from a case and make a mistake. I don't know. I think going to your point, I don't know a single expert who hasn't made a wrong prediction or judgment. And the more we go on, the more we are able to sort of hone in on certain truisms about the virus, about how it spreads, about how it is likely to evolve, how it affects the body. But we're still going to be learning a tremendous amount over the next certainly year. And before we really figure out how it's affecting the body, how the damage that seems to be done, actually the pathways that lead to it. And I like to remind people, the idea that clots and disrupted linings of blood vessels cause heart attacks, or that most strokes are blood clots, those are relatively new. They're like 60 or so years old. So, and they've been around forever. So, it does take time to understand the clinical manifestations of a disease. And I think that's partially why you're getting some contradictory advice. But, let's just review for the audience the things we know for sure. First of all, we know enclosed spaces, rooms, halls, houses, that's where transmission is much more likely. That's not to say there's no transmission out of doors, but it's much less likely. Second, crowds, where you're interacting with people or very close to people, lots of transmission. Where you're getting people's breath, where you're there for an extended period of time, lots of transmission. And then where people are digging deep into their lungs and coming out with a sneeze, a cough, singing, or yelling. Those are the 4 high transmission situations. And we do understand that. And notice, outdoors is not an enclosed space. So that's a much less of a transmission risk. So I think those are, as people are figuring out how to adapt, those 4 items are very, very, very important to keep in mind.
Absolutely. And I appreciate you going back through that, right? Because again, there is this fear of anywhere I go, I feel like I could catch it. So it's nice to put into perspective this idea that there are some instances where it's more likely and others where it's less likely. We're obviously trying to guide people to the latter. Something else that we've seen in this pandemic is just that it's really shown us the flaws in our healthcare system, right? And not that they weren't always there, but we really got this clear picture of who's being harmed or who's being left behind by the way healthcare is managed in this country. So we now know that Black people are 3 times more likely to die from coronavirus than their white peers. And so we're seeing all of these inequalities. We saw lots of inequalities in testing and access to care, et cetera, early on in the pandemic. My question is, in your opinion, how do we remedy an inequality like that and these other inequalities that we're starting to see crop up as a result of the pandemic? And how do we begin to sort of address the healthcare needs of these marginalized communities?
Well, I think that's an excellent point, that we are in some ways exposing underlying inequalities that have long persisted in the healthcare system. So let's try to understand what is causing the inequality. Some of it is related to healthcare, but a lot of it is related to underlying socioeconomic deprivations, and to really sort of equalize health outcomes, which is what we really care about. You're going to have to actually address the underlying underlying socioeconomic disparity. So, some of the inequality in the COVID impacts are undoubtedly due to higher rates of heart disease, obesity, diabetes in the Black community, hypertension also. And those diseases, some of them are healthcare related, but a lot of them are related to issues of access to food, exercise, and other items which are unequal in our society because of how housing is made unequal, how food deserts exist, advertising for foods, and how people can actually access various items. So it's important to understand that if we're really going to address the disparity in health outcomes, we really have to get to some of these underlying causes, what healthcare experts call the socioeconomic determinants of healthcare. And I think that's going to be critical. If we look at, what's the difference in healthcare spending, there's probably in the end going to be, a marginal amount. Or we look at, hospitalization rate, or that's probably not going to be the best way of addressing these disparities. The best way of addressing the disparities are probably going to be looking at some of the underlying causes that get people into trouble. So housing, food, exercise, education, that's going to be critical. Access to hospitals and doctors also going to be critical, making sure that people have physicians who are their primary care physicians who they can access and who they trust and actually follow their advice. So one of the things I think that has probably compounded the problem has been the mistrust, very well earned mistrust of African Americans of the healthcare system and the kind of information they get from the public healthcare system. And so we have to make sure that they actually find doctors and healthcare providers who they trust and whose advice they're willing to follow, because that's going to be critical to actually getting them to improve their healthcare situation. Getting the right medications, following the right medications, having follow-up either in the doctor's office or at home to make sure that other stressors that throw them off their healthcare, their good health, are reduced.
Absolutely. And I love that you brought up sort of that, like you said, well-earned distrust of the community, but how that's deeply affecting Black folks who just aren't trusting enough to go out and get the care that they need. We're kind of seeing this distrust manifesting in other places across the country. We're seeing protests against police brutality. But there's also this larger conversation around these protests of just leveling the playing field for folks in Black communities in every area, right? Whether that's economics, education, and of course, certainly healthcare. So talk to me about what impact you think these protests are going to have for the future of health policy. Yes, there are folks out there shouting for, justice in some of these cases on the criminal justice side. But as you mentioned, all of these underlying policies are also affecting healthcare and their ability to be healthy. How is health policy going to be affected by these protests?
So I think it's critically important to recognize that, and I think one of the things that the protests are doing is to make it manifest that this is not a one-off or a bad apple situation, that this is the way we've structured our institutions, the way we've structured our society, does put minorities, but particularly African Americans, in a very bad and deprived situation. To solve that problem, we are going to have to actually restructure society and recognize that the way we've organized everything from bank loans for housing to supermarkets to food stamps and other government programs have not been designed with an effort to actually promote equality of opportunity and to allow people who are poor to rise in society. And so I think we're going to have to redesign both healthcare, but the wider social fabric. So, just to take the short answer is, I'm not 100% sure. No, I'm not 100% sure how we're going to redesign the healthcare system. And I think it's a little premature to know. The second thing I would say is, since we are trying to change systemic racism, we know that doesn't happen overnight. You have to change attitudes, you have to change institutional structures. And even if we pass laws to change some of that, it takes a while for that to filter into the culture of institutions like hospitals, like primary and secondary schools. So I think there's going to be a whole series of changes that are going to be necessary, and their impact is going to evolve over time. It's not going to be like flipping a light switch and suddenly, we won't have a racially unjust system. But I would say that, there are some interventions we know that we can institute pretty rapidly that would be helpful. Let me give you an example. We know that children born into poverty are at very high stress and very high risk for adverse outcomes, whether they're poor performance in schools, involvement with the criminal justice systems, poor health outcomes. All of those things are much more likely if you're born into poverty. Well, if we want to be a just society, one of the things we have to recognize is we need to invest extra money in those particular kids. Those happen to be kids who are on Medicaid, typically. 40 to 50% of children in the country are born in Medicaid. And so we need to focus some resources. So one of my personal favorites, if I were in control, as it were, of government programs, I would heavily invest in early interventions for kids in Medicaid, something called the Nurse Family Partnership, where we actually send qualified nurses and others out to parents of newly born kids in poverty, help educate them about raising children, about the stresses of life, how to cope with them, and make sure that there's the right kinds of materials for the kids, that there are books around, that the nutrition is right, that they get their immunizations, etc. Those kind of interventions turn out to be incredibly cost effective in our society. If you spend money early on, it actually reaps big benefits for those children in terms of better health pretty quickly, better educational outcomes, they're better prepared for nursery school, and lower engagement in the criminal justice system, and ultimately higher incomes when they actually become adults. So this is the kind of intervention that, you start early, you invest early, and you have to look at it as this isn't government spending. This is a social investment in individuals who we know are at extraordinarily high risk for a bad outcome because through no fault of their own. It's not like the kid has to be born into poverty. It's just that's how it happened. And so I think that's the kind of interventions that would make a huge amount of difference.
Thank you for that answer. Really poignant. Just this idea, again, of trying to invest early and have those interventions, but that there is no easy fix, right? So this is something that we're definitely looking forward to seeing evolve, certainly as we head into new leadership, right, in government. Something else related to the protest that I wanted to ask you about was just this idea of folks really risking their lives 2-3 times over, right? If you're out protesting, there are folks out without masks on, of course, so they're running the risk of contracting COVID. They may get into a scuffle, either with a protester or a police officer, and end up being hurt. And then, of course, there's tear gas being used at some of these protests. And I read somewhere, someone was like, how scary it is, right, to possibly come in contact with tear gas, which attacks the lungs, while we have a virus spreading that also attacks the lungs. Talk to me about the concerns around protesters. Should we be worried about seeing a large spike in COVID cases because folks are out protesting without masks on? And how worried should we be about tear gas being used on these folks?
Very good and complex question. So first of all, I think any conscientious person in America has to be sympathetic to protesters, to frustration about American society, and to the urgency for changing. So that is definitely totally not only understandable, but something that we really do need to support and move forward as a national agenda. Protesting in the era of COVID is, let's be honest, a high-risk game, and it is very risky. So, I went through the 4 things we have to worry about: crowding, closed enclosed spaces, being with other people for a prolonged period of times, and then deep lung aeration, yelling, singing, coughing, and sneezing. Well, unfortunately, protests have 3 out of 4. You're crowded space for a prolonged period of time, and there's a lot of singing, yelling, inadvertent sneezing, coughing, etc. that makes me nervous. That makes me nervous that in 2 or 3 weeks, we're going to see a big spike of COVID cases, especially among younger people. They could experience a lot of complications. And I have to say, it is I understand how people are torn. I understand how motivated people are. But we do have to recognize that this is a high risk engagement and probably higher risk to people than the racism. That's no excuse for us not committing ourselves as a society to the structural change and institutional change we need. But I do think I think maybe not everyone is aware of how risky the activity is. Face masks can help reduce the spread, but these are crowded conditions and prolonged. Let's talk about the tear gas. One of the real problems, I think, of certainly the initial police response, I think it's eased off, but probably not everywhere, is they were crowding people together, then using pepper spray or tear gas that caused people to tear, to cough. So crowding people together and then giving them something that is meant to have them cough, not a good combination if you're trying to control a pandemic where coughing is a problem and where crowding is a problem. And so that's extremely worrisome. And I really do think the police have to stop using both the techniques of crowding people together and tear gas or pepper spray or any of those techniques that, again, make people cough and make people huddle, cry, because that is very likely to also exacerbate the spread. And, if you do that, society and the individuals are going to pay by becoming sick and taxing the healthcare system again.
Yeah, absolutely. And I really share your sentiment there, and that I hope they stop using tear gas as well. Seems very dangerous. And this idea that folks are so angry that they're willing to take that risk is something that we've all probably realized and kind of set with. I know I did. And it points us in this direction of thinking of, well, what can we do better with the criminal justice system? What can we do better with our healthcare system so folks don't have to risk their lives and stand in the streets and protest for things that should already be provided? So in your new book, you explore some great things that are being done in healthcare in other countries. And not to spoil it, because we want folks to buy it and read it, pre-order it on Amazon. But if you don't mind, could you share one or two things that you found in other countries that would be really good for America to bring here?
Well, I think there are a number of issues. I would say one issue which I'm particularly driven by is, and I think intersects with COVID, is one of the things that COVID has done has created a huge number of unemployed people, and a lot of people who are losing their employer-sponsored insurance. And it's not just the workers who are losing it, but their dependents often are also losing insurance. And in many places, they are getting Medicaid just at a time when states are under severe financial stress, and this is just compounding the financial stress of states. Other countries provide health insurance and even allow people to choose private insurance, but don't have the employer doing all the work. They do have the employer helping to finance, but mostly what happens is, and I'll give two examples, it's predominantly Germany and the Netherlands, where employers pay to the government then creates a pool of money and basically gives people a voucher. They can go and pick any insurance company and the government pays most of the premium, and then individuals pay a premium to the insurance company, relatively low premium to the insurance company. People have choice of which insurance company to go to, and the employer contributes to it, but doesn't run it. So that if the employer reduces employment, or say they don't provide insurance, they're still obliged to pay. Or if they have contractors and don't have them as employees, they're still obliged to pay for it. And I think that is a model that we really need to look at. This employer-sponsored insurance we've had since really the 40s is probably not a very good model. No other country really uses it. And even if you want to preserve private insurance and have employers contribute, there are other ways to do it what is much more effectively and efficiently, and it gets you to universal coverage. So I think that's one really good example that we can think of. Another, we studied a lot of countries, and the way we price drugs, we know is broken in this system. There are many different ways of pricing drugs. Every other country regulates the price of drugs, including Switzerland, which has two major pharmaceutical companies. They almost all do some version of the following. They look at a drug, they compare its health benefits. They actually look at how much does it improve the health of the population. They relate the price to that health benefit using objective measures. So they just don't let drug companies set a price. They say, well, how big an improvement in health is it? And that's related to the price you can charge. Some companies even require reductions in prices over time. If another drug that does something similar comes into the market, you have to reduce the price of the first drug. So I think we can learn a lot about regulating drug prices by looking at other countries. And I'm hoping that after this next election, there will be a lot of pressure to actually focus in on drug pricing. So I think that's something where looking at a lot of other countries can help. And as I mentioned, looking at the value of a drug, how health beneficial is it, and then having a regular mechanism to reduce the price depending upon other drugs in the market is really important mechanisms that we can find in other countries.
Absolutely. And you have really good ideas, Dr. Emanuel. I appreciate
Thank you.
that. And so I bring to you a little tidbit from the rumor mill. We're hearing lots of folks talking about the upcoming presidential election, which we know is almost here. And there's been lots of talk that if Biden wins, that you might be someone who is selected to run Health and Human Services. Considering your past experience with the Obama administration, what are your thoughts on that? And is that a role you might be interested in taking on?
I don't know how political we want to be here, but Joe Biden better win. That's job number 1. 2, 3, 4, 5, 6. We really do need a change of leadership in this country, and I do think the vicissitudes that the current president has made, the sort of outrageous comments he's released in the last 2 weeks about when the looting starts, the shooting starts, or you have to dominate people. It's just inconsistent with American democracy, and we do need a different kind of leader. I think someone said, you can afford such character behavior when you're doing really well, but not when you have a health crisis, an economic crisis, and a racial crisis in your country. Then you really need leadership. And so having Joe Biden win is critically important. Let me just tell you, I was raised by parents who took public service extremely seriously, and who thought that your, role in life was to do good in the world, and you do it however you can. And I found that, part of that was public service when I was in the Obama administration. It was extremely fulfilling to me, and I hope helpful to the country to be able to work on healthcare, expand coverage, try to get healthcare costs under control. And if I can be of help to the country in that way, I would. I would just note that, Philadelphia's great forefather, Ben Franklin, said that, the most important question that a man has to answer is what good can he do in the world? And if that's the way I can do good, I'm prepared to do any service I can.
Well, that is exciting to hear. And we'll definitely be keeping our eyes on things as we move toward the election. I don't want to monopolize the conversation. We have tons of folks who tuned in to hear you speak, and some of them have questions. So I want to share some of those questions with you now. One of our viewers has asked, how much progress have we made on ramping up testing? And what are some ways we can make testing more readily available?
It's really interesting that that's sort of fallen off the radar screen, but it's still not anywhere near where it needs to be. We still need a lot more testing. And there still is, it might surprise people, but going back to your very first question, is, why is there disagreement about who we should be testing? And you might have seen a Stanford University Medical Center announce that it's testing all patients coming in, and it's testing all its healthcare workers. And there are other health experts who say that's a terrible idea, because these people are probably at pretty low risk for having an infection. That gets you to what are called false positives, people where you do the test and you get a positive and yet they're not infected. So we're still having a disagreement. And nonetheless, it's quite clear we need to do a lot more testing. We're not even at the million tests a day level. So we still need to ramp up probably to between 3 and 5 million tests a day. And we also need to much more rapidly get tests that are reliable and can deliver answers in 10 or 15 minutes, what are called point of care type tests. This has been one of the fiascos of our response to COVID-19, is why we can't get testing that's better. And it certainly has hampered our ability to respond to this. But testing alone is only part of the answer. You need testing, you need the contact tracing, the ability to isolate people who are positive. But you do need testing that's rapid, because if you identify someone who's at high risk, you got to know to be able to isolate them and not say, well, we'll come back to you in 3 days. That just doesn't work.
Right. And it's interesting you brought up just having more reliable tests. There's also this conversation around immunity passes, or this idea that if everybody just gets these antibody tests, which tells you, hey, you don't have it now, but you've had it in the past, then that'll inform us on who should hypothetically be able to move about the world as normal. Talk to me a little bit about antibody testing and these immunity passes and what we should be doing in that area.
Well, we wrote an article in JAMA about immunity. Well, we call them immunity licenses, not immunity passports, because passports sort of make it sound like, you can't go. First of all, our conclusion is that they could be ethical if used in the right way and if the science supports them. And we're still not there at the science supporting them. So, for example, we don't know if you have a high antibody, are you protected? How long are you protected from the infection? And that is going to be critical to being able to say whether the immunity licenses mean anything or not. If we have people who have high antibodies but can continue to be infectious and transmit the virus, that would be a bad thing. And that would suggest that these immunity licenses are not going to be something that is useful. On the other hand, if people who have had COVID-19 or then get a vaccine and have a high level of antibody, if they could work in certain jobs, if they could visit nursing homes and people without transmitting the virus, or work in hospitals without transmitting the virus, that would be good for them and it would be good for society. So we should probably keep an open mind about having them once we nail down the science related to the immunity passports.
Yes, thank you for that. We have another question from the audience, which is very important to many of us on the line who are probably thinking about summertime and getting outdoors. And one of the things on everyone's mind is, can we go swimming? And is it even safe to do so, either in your apartment pool or the pool at your condo or a public pool? Is it safe to go swimming, or is there some risk there with catching COVID?
Well, again, being outdoors is a good thing. Being close with a lot of other people for a prolonged period of time and in a crowd is not a good thing. And so I think that's what you really have to measure. And remember also, swimming, especially if you're doing laps, you're taking a lot of deep breaths and exhaling. And if you're exhaling into the face of the person in the next lane, that ain't going to be a good thing, even if it's in a swimming pool. I think it's probably better and easier, frankly, if you're going to a big beach and they've limited the number of people on the beach so that there is sufficient social distancing and you don't have what we saw early on in Florida, which was a huge crowd of people all right together, spending a lot of time, literally shoulder to shoulder in each other's faces. That is not a good thing. Or when we open up Ocean City, and people are crowding the boardwalk. That is not going to be a good thing. That is, again, crowds, breathing in other people's faces for a prolonged period of time, and coughing, sneezing, singing, yelling. That's not a mechanism to control the spread here. So I think when you go outside, and again, I encourage people to go outside, you've got to use think about the 4 mechanisms that are critical to increasing the risk of transmission and make sure you reduce each one of them. And by the way, the other thing that's a problem with swimming is you can't wear a mask over your nose and mouth. And that also is very important when you, for example, go to the beach and things like that.
Yeah. Good points that you raised there. Just this idea that folks can get out, but we still need to keep social distancing. Very important.
Well, I mean, one of the advantages of Philadelphia, if I might say so, is, and we don't often appreciate this, is we have a lot of parks and we should use those parks effectively to go walking in, walking along the riverfront, as long as you're staying away from other people. That's a good mechanism to get out. And if you're looking for exercise, running, riding a bicycle, rollerblading, those are things where, you're staying far away from other people, and, you're not going to hurt them by being in a crowd or necessarily deeply breathing right into their face.
Right. So taking advantage of the beauty of our landscapes. We have plenty of...
fill it out. Look, I love the riverfront. I love the Wisconsin Trail and all. Great.
Yeah. So another question from the audience is just about how we can get Americans to start taking better care of their health. So when you think of all the underlying conditions that are exacerbating something like COVID, and even thinking ahead to maybe some other virus sprouting up, how do we start to get these underlying conditions in control from a policy perspective? How can we encourage Americans to take better care of their health?
That is a great and challenging question. So we do know that critical to the spread of or the risk of getting COVID is obesity. And we know that obesity is a complex situation, but fighting it, requires several things. It requires changing our diets so that we're eating better. We're eating less processed food, less sugar, and empty starch calories. One of the great things Philadelphia has done, I believe, is the soda tax. We've seen that the soda tax does make a difference in what people consume. It decreases their consumption of empty sugary calories, switching people to water and other drinks that don't have calories. I think that's it's one step. Is it the solution? No. But if we train people, don't focus on the sweets, focus on nutritional food, that's important. We also need to have people exercise so that, again, part of this is habit. How do you build it into your daily, weekly routines to actually go out there, and whether it's walking or running or riding bikes, etc. And again, it's easiest to build it in for children. And I think that's the kind of thing that we need to think through. How do we change the eating behavior? Is it going to involve pain? Yes. Changing habits is never easy. Some store owners who have made a lot of money on smoking cigarettes, on sugary soft drinks, yes, are they going to lose money? We have to figure out how to make that less painful for them. But we can't say, because we want to save store owners who sell sugary drinks and cigarettes, we're going to let other people die. They won't die today. They'll just be obese and die of other illnesses down the line. I think that's a bad trade-off for us to make. Am I sympathetic to the store owner who's seen revenue go down because of the soda tax? Absolutely. But I don't think we can allow them to make a living off the ill health of our fellow citizens. And I'm especially proud of the fact that, Philadelphia has used that money to invest in parks and invest in pre-K, which I think are very, very also important in trying to get people to live healthy lifestyles.
Absolutely. So we have one more question from the audience. I think we have enough time for, and that is a question about coronavirus again. How far are we from a treatment or a vaccine for this? Because we know everything we're doing right now is preventative, but it'd be really nice to have a treatment or a vaccine so we could kind of get ahead of things. How far off is that in your opinion?
All right, well, let's distinguish the two. So a vaccine, early in July, we're probably going to start big trials to test out vaccine. The United States government has selected 5 companies for their vaccines: Moderna, Johnson & Johnson, Pfizer, AstraZeneca, and now and Merck going forward. If everything goes well, and it's rare that everything goes well, sometime in the early 2021, middle 2021, we may see the real effectiveness of a vaccine. When that translates into all of us being able to get a vaccine, probably middle of 2021 to end of 2021 is most realistic. So that's for a vaccine. And again, I think there are lots of things that could throw it off. The fact that we're betting on 5 different approaches helps the chance that it'll work. But we should be aware that if we do get a vaccine, there's going to be some gap between, yes, this is effective, and yes, you and I can get it, because we need production, distribution, and administration. You finally have to get that shot in your arm. Therapies is a different question. There are lots of leads, and so far we have one drug, remdesivir, which is a modest effect. Probably, and I think a lot of experts think we're going to need a multi-drug cocktail, 2 or 3 drugs that we take for treatment. And my position for a while has been, there may be some things off the shelf like remdesivir that might work, but we're probably going to need drugs that are really tailored to this virus and the way this virus works. And that's a longer development time, because you have to find the right drug for the particular virus. That's what we did with HIV. That's what we've done with other illnesses. So my suspicion is that's going to be a little longer in the making. We've just had some recent data on convalescent serum may not be as beneficial as we thought, but the final decision is still out on that drug. Importantly, we've learned how to manage this illness a little better. We know that putting people on ventilators is probably not that good. Maybe we should avoid ventilators and use high-speed oxygen for them. Maybe by some of the techniques we can avoid, needing as much therapeutics and managing people well. The one thing, or the 2 things I'm really worried about is our long-term effects. One is we don't know what the long-term lung effect is of having COVID-19. Do you get permanent damage? Are you getting scarring? Even if 20-year-olds don't get really sick, do they have long-term lung damage that might affect them, when they're 40? We won't know that for a long, long time. The second thing I think is we do know that there's a lot of mental health issues associated with COVID directly and the stresses it induces and the isolation, with all the unemployment and the economic consequences of COVID. And we have to do a better job as a health system of addressing those, whether it's depression or anxiety or loneliness or, God forbid, substance abuse that arises from COVID. And I think that's going to be a big challenge for the healthcare system to make that much more routine in how we care for patients.
Absolutely. Well, Dr. Emanuel, I think we have just about reached our time. I want to thank you again for making time to speak with me and to speak with everyone who tuned in today. And thank you to everyone who tuned in to listen. I hope you guys will continue to check into the other ThinkFest events throughout the week. Thank you, guys.
Thank you. Great to be here.